So with this, we now go to the Shankara Eye Hospital and over to the live view from the Shankara Eye Hospital Operation Theatre. And we're really grateful to Dr. J.K. Reddy and his team to allow us to peep into their operation theatres live. And over to you, Dr. J.K. Reddy, and to your team.
Good evening, and I thank AOS for giving this great opportunity for us and for our hospital. And the first case is a mature cataract. Dr. Prabhu expert doing all this type of surgeries in our institute, he is doing the first case. I think it's on live the surgical field, and it's intermittent cataract. So he's starting surgery. So we do a non-touch technique here, that we don't touch any conjunctiva or anything during the procedure. We just support with the side port and make the main incision with a keratome and make the side port. So both will be finished in single go. So this is a intracameral Zalakin. We are routinely using every case intracameral Zalakin. Now, as usual, this will be a regular Trypan blue. Only thing is we are waiting to see how things goes on and any modification necessary on the table, if necessary. Illumination கொஞ்சம் increase பண்ணலாம், microscope illumination increase பண்ணலாமா, ஒரு point increase பண்ணுங்க தானே. Yeah, it's well strained. Yeah, beautiful. So this is methyl cellulose, 2% methyl cellulose going into the antechamber. My surgeons, they don't like to talk, so I had to do the talking job. And he's aspirating with the side port. He went with a 26 G needle and a 5C syringe, and he's aspirating. As he's aspirating the capsule, you can see it is stretched a little bit, then it is stopping. And this is methyl cellulose going again.
You don't prefer high viscosity viscoelastic in such thick length?
I use, to be frank, I use it, but these guys are young, they are overconfident.
They're doing a great job. They're doing a great job.
Yeah, I go for once, I do the aspiration part I do under methyl cellulose, but the capsulorhexis I do with a Helon or Viscoat. Or otherwise RO coat from Indian companies or something. I use it, but these guys, that's what I put them today all in surgery. Probably I will not be doing.
But the control is fantastic. Yeah, fantastic control.
This. So nothing, I am expecting some surprise and I want to see how they manage, but nothing has happened. To my little bit disappointment for me.
Beautiful capsulorhexis has happened, Dr. Reddy.
This routinely, I will be watching now and then. I will come and watch them seeing surgery because I enjoy their surgery, both Dr. Prabhu and Dr. Siddharthan. So I enjoy more their surgery than my surgery doing myself, because I can leisurely sit and watch surgery, which we cannot do when we are doing surgery. As far as the machines are concerned, right from the beginning, for the past 20 years, we are with J&J, or initially with Abbott and Allergan.
This is which one? Which machine?
This is the Signature Pro. Signature Pro. And I think next year they are going to come with a new one with the GFI, gas forced infusion. Whichever comes, we will use that one. Right from the days of Diplomax, we are using mostly there.
Okay.
So now this is the endonucleus.
Yeah.
He likes to do like that. He separates the endonucleus. He won't chop in the center most of the times. Prabhu, konja out of field, Prabhu.
Okay.
No, okay, no problem. So நீ கீழே உட்கார்ட்டு பண்ணு தானா உட்கார்.
Just getting a little decentered. Can you guess?
Yeah, I'm asking them to center. The surgeon is కొంచెం decent, Prabhu.
He has to bring it towards himself.
Okay. Out of focus. Yeah, he stopped to make it. This is the usual in live surgeries because we want to recenter. Sometimes we go out of the way. This is a typical sharp chopper. This is our own Dr. Mohan Rajan chopper, where it is just a straight sharp one. It's a 1.5 millimeters length. We tried 2 millimeters. Somehow we are not comfortable. We are more comfortable with 1.5 millimeters.
1.5 is a reasonable sharp, thin 1.5 millimeter. It does the work very well. I also feel that's a good one.
Blurred இருக்கு கொஞ்சம் focusing. Okay. Anything different can we do in this case, but it is going as per textbook rules.
Yeah,
that's what I'm saying. It's as if Dr. Prabhu's instruments are following your commands. You are saying it before, it's going perfectly.
Yeah.
So I'm sure Dr. Prabhu would consider enlarging this capsulorhexis after.
Yes.
The fluidics control is really good with the machine in which he's operating. I think.
This Pro we found is much better. I mean, there is a lot of difference between the Pro and the Signature, and Intuitive also. The new one also very good. We are having 3-4 machines Intuitive also in our institute. One Pro and in other all operating rooms we got 4 rooms, 3 Intuitives and 1 Pro. We changed all. Before we had compact and sovereign, but once we start using this, we are not able to use the old ones. So we changed all the machines. So except for the last piece, the remaining most of things happened within the bag. So we expect a clear cornea in this case, in this patient.
Very nicely, and it was a very controlled, very good control throughout the procedure.
The thing I like with this J&J or Abbott systems is the incision. You look at the incision, we can't even see where the incision is. Whereas with the other systems, we tried other systems. By the end, the surgery is finished. The corneal incision will be white and hydrated. Here it is almost, we have to really search, where is the incision. That's what we love. So it's very, very difficult to produce a wound bond with this. Unless you are really want to produce, you cannot make a wound bond with the J&J systems. So that's why somehow I like J&J now. Once upon a time it is Abbott. So And this is a eye-hands lens going for him. This is one of our favorite lenses. And we are expecting that all companies will make this type of, I think, as I told you last time when we were discussing, most of the Indian companies, they launched this model one way or the other, but the original is still wonderful. And we are requesting them to introduce in a toric platform so that the maximum benefit patients will get. So they are telling they need another 6 months to 9 months to launch in a toric platform.
Okay. This eye-hands lens has really done quite a great job in the sense that, the cases wherein you want some degree of, some degree of depth of focus, but in cases like, in diabetics, etc., wherein you don't want any multifocal, or you don't want, patients with, diabetic retinopathy, you're doing cataract surgery. So it's a monofocal lens, but with having some advantage of
the microscope light is gone.
Yes.
So monofocal lens with some degree of depth of focus, which can be used in tricky situations like in diabetics, etc. Meanwhile, while they are setting, I think maybe Dr. Namta, you also have used eye hands quite a lot.
Yeah. I think it's a great lens, Rajesh, especially for the fact that it is so affordable and it serves the purpose of giving vision at distance and near and intermediate. And I think as we were talking, excellent demonstration Dr. Prabhu is showing of how a small rexes can be enlarged.
This is a vitreoretinal forceps, membrane peeling forceps from Grishibar, and now it is owned by Alcon. It's very nice. This gives, it's a wonderful forceps.
The forceps is also nice, and the way it is being handled is also very nice, because I can see the way he has enlarged it. It is absolutely circular. So that is something which I would really like to compliment Dr. Prabhu here. Sometimes, while enlarging, it goes slightly away on one side and all that. Nothing of that sort has happened. It is absolutely perfect. So that's really good. Very nice.
Now, for IOL implantation, we use sodium hyaluronate, something like Helan. We like to now using a lot of Indian companies because we want to save some money a little bit. So for IOL implantation, we are not using methyl cellulose.
Okay,
So nasally, usually temporarily, we like to enlarge a little bit more. Somehow it stopped there, but we are not re-attempting this time from the side port, because we need to enlarge side port to do re-attempting of another small rexes on the temporal side. So right now we are closing the case. And the second case is DMEK. We'll be starting immediately. This is intracameral moxifloxacin gone at the end of surgery.
Excellent, Dr. Prabhu.
Excellent surgery, Dr. Prabhu.
Usually, as usual, this is the same surgery, same thing. The patient just walks home with the eyes not padded. That's I think it's the universal anywhere. And a long time back, we used to move in wheelchairs and take the patients. We thought that produces more contamination of the theater, so we are asking the patients to walk instead of moving them in another wheelchair or stretcher, something. Nothing. We found this is more giving more sterility to theater. Patients walking away than moving them with some wheelchair, something like that. The second case we are starting. There's a DMEK, Dr. Siddharth. Starting that, shifted. Yes, Siddharth. Yes, you ready? What is the patient, Siddharth? Is a PBK. It's a case of pseudophakic bullous keratopathy, and he's harvesting the
PCIOL.
Yeah, this is DMEK. DMEK case second.
Yeah. No. Is pseudophakic bullous retinopathy with a PCI well?
Yes, PCI well. PCI well. Meanwhile, he started that. This is clear. View is clear, you know.
Oh, view
Yeah,
is perfect.
absolutely.
It's as though we are seeing through the microscope. The view is so clear, even for the last surgery and this also. Hello, Dr. Siddharthan. How are you?
Yes, Siddharth. Yeah, he's not having a mic.
Okay.
Yeah, he just started. Say hi.
Hello, Namrata.
Hi.
Hi, Siddhartha.
Hi, Rajesh.
So Siddharthan, it's a treat to watch you do DMEK surgeries.
Oh, thank you, Namrata. Thank you for your compliment.
So this is what size trephine?
Okay, this is a 10 mm trephine. So what I do is first I just mark maybe a very partial mark, like maybe 100 microns or 200 microns. I just mark it. Yeah, blue.
I mean, I just want to inform you there's a record number of people watching on Facebook and YouTube. We've never had so many before. So not that I want to this thing you, but just to say that, it's a treat to watch a surgery like DMEK.
Yeah,
And
so here
yes.
what I do is, I leave it for 2 minutes to really stain the DM. The staining is very important because it just impregnates the DM and it's thicker and it's easier to remove. So this we have learned over the period of time.
How old is the donor?
Around 60 years.
Okay.
So why mark and then I put the blues, because the mark becomes really prominent. So that's why I don't put the blue before the mark. So as usual, under the scuba technique, I'm putting saline. So make sure that you don't put the saline over the cornea. You just put it over the scleral part. I use a normal Sinsky. We just delineate the DM.
Microscope is too good, I think, because you can see everything so clearly.
So with Sinsky, actually, it's better not to have tags, but tags are actually happening. But so when tags are there, when you pull the DM, you have to be very careful.
This is the McPherson that you are using, Dr. Siddharthan.
Yeah. Just a small, just a non-tooth tying.
It's just a curve tying forceps. So
Okay.
We generally, this is one of the forceps we bought almost 20 years back from Einar, when Ivan Einar was making the company is closed, but still it's working. It's a beautiful forceps.
So what I do is I do a 360-degree release before I actually attempt the. Sometimes you see here, it can get tagged. So I usually go at that portion and I try to release it.
So I think what happens for us is that all surgeons in India are making their own tissues or preparing their own tissues. In the all the other countries like in West as well as in the Asia Pacific region, the DMEK tissue is already prepared, in the eye bank by the eye bank technician. So all the surgeon needs to do is just inject it. But for us, I think most of us, at least 90% of us, are having to prepare their own DMEK tissue.
Yeah.
So advantage of preparing our own DMEK tissue is that, you know how the DM is going to behave because you've only stripped it. So you know how it is going to behave intracamurally. And you know whether the scroll is going to be tight or it is going to be okay. But if you've not done it yourself, then obviously you'll have to figure it out when you're actually doing the surgery.
So the 3mm punch. So this is for making a small button so that I can mark the stromal side. Bloomer. So make sure that we don't put the saline over the cornea. We should put it over the sclera so that the DM doesn't get. Sponge.
So Siddharthan, what would be the youngest donor that you would have done?
So around 45.
Okay.
40 to 45.
Anything specially do to unfold that?
Well, nowadays with that, whatever age, it's pretty easy to remove. I'll show you the technique which I use. So whatever age, it's not a big problem. I don't tap. I don't use the tap method.
Okay.
Just hold and release the to hold and release technique I do. Okay. It's actually very simple when you whichever tissue you use. So age, I think below 40 is pretty difficult to unfold. So I've never tried below 40. This is an L mark which I regularly use. So with a horizontal limb is shorter, and the horizontal and the vertical limb is longer.
Any specific reason for this L mark?
Rajesh, the thing is, Rajesh, I feel more, but this is S because in India we do, this case what I have selected is a pretty straightforward case, but otherwise we have some scarring and all these things. Yes, I find it really difficult to, this one, what I make is like, when I inject in, I just need to see the small, this arm only.
Yeah.
So it's pretty easy. Yeah, only the small arm. I don't need to see the big arm.
Okay. Yeah.
Quite right. Actually, sometimes S curves can be very confusing.
Yeah. So I now prepared the tissue. So I just usually put some blue and saline, and I have not prepared the patient. So usually I prepare the patient and then I punch the tissue.
Actually, I thought you would use S. S is for stromal side and also for Siddharthan.
Yeah.
No, Namrata.
I also feel that S is for Sena. So
okay.
And S is for Sharma, so that is why I can't leave. Although
Yeah. S is for summer also. So
yeah, so we all are trying to find our identities in it.
Height. Height slightly. Okay.
So like you said very rightly, and I think Rajesh, you would also agree that we see, a lot of DMEK cases being done by surgeons from the western part of the world, which are so clear. But when it comes to our country, it's like, you know, what the way Siddharthan is showing now, the corneas are so hazy that it is very difficult to, you know, visualize the
Very
graph
true.
and the marks, etc., etc.
Very true.
And ones which are done that side, I mean, if you see, sometimes you even think, why are they ever doing it? The cornea.
So most of the cases, DMEK, I remove the epithelium. I don't, even if it's a little bit healthy, I don't leave it, because I feel that post-operatively, even intraoperatively, the view is better once you remove the epithelium.
Yeah, it
And
has
also
improved quite a lot.
yeah, and post-operatively, the new epithelium usually grows very fast without this epithelium. So I usually, before I used to do sometimes without removing, but I make sure that I remove 8.25. So this other eye I had done a DMEK. So nowadays I try to do a bigger graft, like almost near limbus to limbus. I try to do. Before I used to do lesser size, but lot of times after a year, sometimes we see peripheral edema things, and even immediate post-op, it takes some time for the cornea to actually recover. So nowadays I'm doing larger grafts, so like.
So this is what is the size of the trifine?
8.25.
Okay.
Previously,
Actually,
I had used previously I had used 8 in the other eye. So this I thought, okay, I'll do a slightly.
Yeah. No, you are quite right. The area which is not covered by the graft, whether it is DMEK or TSEC, you will see peripheral bulle there in the post-operative follow-ups.
Yeah. And it takes time, and patient keeps complaining.
Yeah.
So I thought, okay.
So if I can ask, you know, these small things make a lot of difference. Your gentian violet pen is very good. So what is it? I mean, we tend to use the one which we get from Viscoat, and the mark is not that good. So what company is this gentian violet pen which you use to mark?
Actually, this one, what he used is a water-soluble skin marker
Okay.
for plastic surgery, but sterile one with gamma radiated.
Okay.
Now again, there is some short supply because of the cargo problem. These are all not made in India. That is the biggest problem.
This is a 2.8 keratome. I just slightly extended to make it 3. So I prefer to remove the DM. So a lot of people do without DM also removing the DM, but I always prefer to remove the DM. What about you, Namrata and Rajesh? Like,
yes, for DMEK in every case.
We do it before only. That is how I think we all have learned it.
We actually remove a little larger than the donor size.
But I used to do that, Rajesh. What happens is, like, previously, like I told, no, this bulle starts to form. So I don't take. I try to leave whatever remnant. I don't try to take the too much of periphery, because that used to. If you remove that and you don't replace that portion, it remains sedimentous.
That's true.
So that's why I don't really, nowadays I don't remove the peripheral.
So desmetorexis you did under viscoelastic?
Yeah. So I do under viscoelastic. I try to remove, because what happens is, like, I sometimes with air, sometimes with like saline, I don't like to damage the iris, because in DMEK, if the iris becomes a little bit floppy, iris is peaked or something like that, it becomes difficult to actually manipulate the DM. Actually, the iris is the best friend for us when we do the DMEK. So this is pilocarpine. I'm using a pilocarpine to constrict the pupil before I do a PI.
So you do PI for all your cases?
Yes. All my cases, I do an inferior PI, because I don't burp the air. I leave a total air and I don't burp the air.
So I think I always felt, and I still feel that, to do a live surgery DMEK is always more difficult than to do a live surgery DSEK. Rajesh, what do you say?
Absolutely agreed.
You have to be
Completely
really
agree
brave.
with you.
You have to be really brave to do a DMEK live surgery.
Yeah. That's very true.
I've been like doing quite a few for quite some time. So
Yeah.
so that's
I remember you started much before anybody else in India, and all your videos have been really landmarks, the DMEK teaching videos and the techniques that you have given us.
You don't use a cutter to make a small PI?
No, Rajesh. See, what I want to do is like, I don't know whether I got it. I like it to be slit shaped. I don't know, because this one I don't know whether I got it slit, but yeah. So I like it to be a little bit slit shaped. I don't want to be round because it's like actually I made a bigger one, but usually I like to make it a slit shaped because as I don't burp the air, so even if the air little bit get released, there is no touch of the. I don't like this size of PI, but somehow there's no option. So I'm going to punch 8.25.
This vitreous cutting, vitreous cutter PI, they bleed, not too much. Little bit bleeding will be more than scissors. That's what initially I used to do routinely. Then we saw that. Then again I shifted back to scissors. I feel that they bleed little more than scissors cut.
I agree with you on that, Dr. Reddy, completely. That the PIs that you do with the vitrector bleed a little more than the one with the scissors.
This is 8.25, same size I'm punching.
So if I may ask, Dr. Reddy, what is the microscope? I mean, because the reception is really too good.
No, Lumira only. Lumira, not even I. Lumira. This is a halogen one, not the LED one. The color adjustment and contrast adjustment is a little easier with halogen bulb than LED. LED bulb is very, very difficult to get the high contrast image. This is a single chip camera only, simple single chip camera, but a HD camera.
So
not even 2K.
Yeah, all our delegates are saying amazing clarity, while
doing it. Yeah, somehow we got this combination. So when I want to change a little bit cameras, my surgeon says, you do anything, but don't touch this microscope. So I'm not doing anything with it. Yeah. We just left it like almost for 5 years. It's left like this with this combination of camera and.
We have a huge viewership on Facebook today, Rajesh. If you just check that.
So this is neither a tight scroll, not a loose scroll. It's basically ideal scroll.
So what is this injector?
This is same J&J Technics cartridge. We cut it and attach it with a silicone sleeve to a 1cc syringe. So somehow we like that 1cc syringe. He also likes the same thing, Siddharth also. I saw many surgeries where they are using 5cc, 2cc. I don't know. We found 1cc gives better control than 5cc or 2cc attached to the cartridge or aspirator.
So J&J also would have never thought, that they could use their injector for DMEK graft. So that is, one, what do you say, off-label use of this injector, which...
it goes very controlled way. Whereas 2cc, 5cc, when you inject, somehow the force of fluid is not we had initially the grafts coming back. We had all the videos. But nowadays we don't get that. Even if we want to mimic also, we don't.
No. We don't want that demonstration right now here.
Yes.
So
So
that then all the referrals for DMEK are now going to come to you because you've done such a superb surgery.
still the tough part is there, Namrita.
Yeah.
So one thing what I want to tell is like usually when I inject, I try to make the speculum a little bit loose so that it doesn't sit. So that otherwise, when you inject, it becomes a problem. So always make the AC a little bit shallow.
Shallow.
And, yeah. Even the suture I put a little bit tight so that it flattens the anterior chamber, and always in a month you can remove it. One more time. So,
and that too, when the chamber is shallow, even if it's
Yeah.
on the tighter side, once you inflate the chamber in the end, it becomes regular. So,
so now the prop here is like I have to make it like a horizontal so that like I can use the other.
So, do you think, Dr. Reddy, with the larger grafts, is it easier to open or difficult to open, or you think it makes no difference?
Actually, we are not finding any difference. I think
Okay.
we learned by this time, how it behaves.
Excellent.
For beginners, starting people, you may find larger grafts difficult.
we can't hear you, Dr. Reddy. Can you hear?
Yes,
the larger grafts for beginners, it may be difficult.
Yeah.
But at this stage, after so many years, almost for 8 years, 9 years down the line, we learned the tricks how to open them. So we are not finding any difference between larger and small grafts opening.
So this is the two-hand technique. So I inject saline and shallow it.
Nice.
Excellent.
You can see the L mark. So
Yeah, perfect.
Yeah.
So now so I don't do any tapping. So just left hand, just little bit for the positioning I tap.
Yes.
That was really mind-blowing.
Yeah. Wonderful. Yeah.
I don't make it full saline. I put a little bit smaller air bubble and make sure that I push with the air bubble and make the any peripheral DM is folded. I try to do it, and then
I think that's a very useful trick, Siddharthan.
Yeah.
So I go with the
Even
full
I
air
have
bubble.
learned today that with a small bubble you can bump out, you can iron out the folds if they are there.
So I think you're able to see that L.
Yeah.
Yeah, we can see.
You can see that if you put a little blob of viscoelastic Visilon, it will get magnified a little more.
Sure.
I think that is one way of, sometimes when it gets hazy and you can't see your S or your L, then on the surface you just put a blob of viscoelastic, then it'll, for that split of a second, it'll get magnified and you can see it clearly.
Beautiful.
Perfect.
Yeah.
Excellent, Siddharthan. I said I was not wrong when I said all the DMEKs are now going to follow you.
Yeah, absolutely.
Even mine I'm going to send to you because we don't have to do here.
For the kind words, and I think I hand over to Dr. JK, sir. Yeah.
Excellent.
Excellent. Mind-blowing surgery.
That was a treat to watch, really.
Yeah.
Thank you, Rajesh. Thank you.
We need 4 to 5 minutes to shift the patient because we need to adjust the second table. These microscopes, we have another Leica, but that, as you are telling, that's not very good in the video. This gives the best.
Yeah.
So you have to wait for patient to shifting.
No, that's fine. Dr. Reddy, even the first case was very nice. I touch wood, the reception from your OR of both the surgeries was just, excellent.
The next case is a 60 years old lady. The left eye was operated a week back. The right eye was operated somewhere else sometime back. She had a scleral fixation of eyeball done. Both the haptics are outside conjunctiva with the tips coming out. It looks very interesting. Dr. Prabhashankar is going to do that case I asked him what your cornea is also not very healthy. There are two choices here. One is whether converting its scleral fixation to a Yamani technique by applying the heat and making the haptics bulbous and inserting them inside the sclera, or he has to explant and put a posterior iris claw, which we routinely do in our hospital for more than 15 years. Now he said he will first try to see on the table. If possible, he will try to convert that into modified Yamanis technique, or if it's not possible, then he will explant and go for a iris claw, posterior iris claw. This case he is operating under local anesthesia. Actually, we don't need, but somehow.
So I think there are so many congratulatory messages. Dr. Jayaprasad Bhaskaran, excellent technique. And Dr. Jayashree Suratkar, superb, simply superb. Sudarthan, Dr. Meena Lakshmipati, and Dr. Leila Mohan, beautiful. So that it's full of congratulatory messages for you, Dr. Siddharthan. I think excellent way that you did the cases.
Very smoothly done, and I mean, it was absolutely flawless, what one can say. Very smooth surgery.
So Rajesh, you deal with a lot of cases where you have to do glued IOL. So what is your preferred technique till the time that we just shift to the next case? Again, I'm sure it's going to be a very exciting case that we are going to see the next, where the plan has to be formulated on the table itself, whether to do a glued IOL or to do a posterior fixation of the iris claw lens, or to convert it into a Yamani type of technique. So what is your take on the various techniques of glued IOL, Rajesh?
I still feel that if we fix a segment of haptic by whatever means, then the IOL, the pseudophacogenesis is significantly lesser in the post-op period while the patient moves the eye. So that is why Yamani technique is a wonderful technique, but then we are not fixing a segment of the haptic. So then it somehow behaves like the suture one, wherein you remember we had done a thesis wherein the pseudophacogenesis was compared in the two techniques, and then it was found out that when we fix a segment, then the IOL is more steady and it doesn't move too much. And when there's less pseudophacogenesis, there is less chance of traction on the vitreous, less chance of increase in macular thickness. So
I think you're quite right, Rajesh. I think they're ready with the case.
Yeah. This is the Yamani technique. How you pronounce, I don't know, is the exact name, the Japanese name. It's a very simple technique.
Very simple technique. Absolutely. Very simple.
But it's not. The results are not great. The lens tilt is very, very high. What I heard, even in my Paris conference, there are so many sessions they are conducting. How to control lens tilt Yamani techniques.
Not only
tilt, lens tilt, post-operative lens tilt, how we can manage that per-operatively during procedure. So this is a universal problem, it looks like.
Not just that, even the lens movement, pseudophacogenesis is a little higher in comparison to the IOL in which the segment of the haptic is fixed. So intrascleral haptic fixation, if you do, the IOL is a bit more stable. The movement is less. So less traction, less increase in macular thickness. But I think this is a good one wherein if the tip can be made bulbous, then you can get away without doing much.
So Dr. Prabhu is operating Dr. Reddy?
Yes.
Okay.
Yeah, now he is making it bulbous on the temporal side.
Yeah. He will finish the surgery in 2 minutes.
We don't know.
So
which cautery, which thing he is using? Which one? Dr. Reddy, which instrument he is using to?
Yeah, the cautery.
Yeah.
The cautery is this is the same with the original one they given in the article. This is in India. Epsilon is marketing.
Okay.
This is they say low thermal cautery.
Yeah.
They are charging a little more. They are charging almost 14,000 rupees. But internationally also, they are charging almost $100. They are asking more than $150. They are asking.
So I'm
So
sure.
that part.
I'm sure with these kind of cases, glue diodes, which are being done now, right, left, and center everywhere, you may have a case scenario such as this, where your haptics are exposed, and I think beautifully it was cauterized and it was tucked.
Yeah.
Rajesh, what do you say to that?
Yeah, I completely agree with you that, if you can perform a procedure with a good centration of IOL with minimal manipulation, I think that should be preferred instead of explanting and putting another lens and fixing it or doing a retrofixation or whatever. So I think I was also just thinking about it that probably this side of the haptic is a little more out. And
It was longer, so I think he's
yeah.
to make it shorter, and then now again.
Yeah.
So would you have done it differently, or would you have also done similarly? Only thing is that I don't know. We are not using too many cauteries.
But this is a good way to manage the case because there's minimal manipulation that is required. See, the basic idea of doing any procedure, because the ocular tissue is so soft and so reactive that if we do less manipulation, the results are better. So I guess in this particular scenario, what Dr. Prabhu is doing, I will completely agree with him. And I would love to follow this thing. If I get a case, sometimes in near future like this, then I would love to follow this technique.
Actually, we plan for explantation, but the cornea is not healthy. If I do explantation, definitely it needs a DMEK up sometime. So
there's one more option. Maybe we can do a peritomy and see what is the scleral condition there, and then we can make a small groove wherein the haptics can be introduced.
Retucked.
Yeah.
But I think these are the things which we need to, really see and watch. Because
absolutely, it is a very good case selection.
Very good case selection, I must say, and very good management to show that less is more here. And so, what can be done with the least amount of disturbance? And these cases are, coming up with the glue diodes which are done, and they might just pop up at your clinic or in your center or in your hospital, and then you would exactly know what to do. So beautifully done, and tucked underneath the conjunctiva so that there is no exposure at all.
Absolutely, it's all done. We will have to thank Dr. Prabhu very, very, in a very short time.
Somehow this scleral fixation, so much they talk, it's not unusual to see a complication in long term. It's not very, they say we don't get any complication, nothing like that. Scleral fixation.
No, actually no procedure is without any complication. And there are many.
That's if you don't do it, you don't get complication. If you
absolutely. So sometimes what happens that when you create a flap, when you're doing tucking the haptic, when you're doing maybe the superficial scleral dissection is too thin, and then what happens, it passes through, cuts through the superficial sclera, which is very thin, and then it comes out. So all these things can happen once you do such a procedure. But then, I mean, it's something which people would love to, would definitely record and want to see every time when they get such a case. Wonderful.
I just want to take your viewpoint, and Dr. Reddy, yours too. What do you think, what technique the initial surgeon would have used, that the haptics are not in the tunnel where they should be, or they are, just outside, and they were not cauterized also, they were a little longer. So what do you think the surgeon has used? He's just taken it out.
This particular case, the lens is only 13 millimeters. This is a sensor lens they used, 3-piece, and but the limbus measurements is coming almost 13 millimeters there. I think during manipulation, the haptics have changed their shape. It's got stretched out. So the shape has changed. That's produced some distortion, which is not going back. So that gave a surgeon a surprise on the table, that I feel. Otherwise, it is an unusual one to see both the haptics. One haptic will come, the other haptic, it's very unusual. Totally now we measured, it's more than 14, 15 millimeters. Impossible. There is no lens available, such a big size lens.
Yeah.
True. The other thing is, because of that reason only, maybe the tucking was too less. He just tucked the tip, and the dissection that was done was also very superficial. And then after that, it slipped, and on both sides it came out through the conjunctiva. So maybe that is also, and that's also primarily because the corneal size is quite big. So the tucking was not that much. I don't know.
Yes.
Maybe that is the reason.
That's what you are doing.
Sometimes in one of the cases, what was referred to me earlier was because of the very thin superficial. The surgeon himself told that the superficial flap was very thin, and the haptics, they eroded through the sclera and the conjunctiva. So all these things can happen if the procedure, if the just minor, defect in the procedure that has been done. But yes, wow, the way it has been managed in this particular case was really, mind-blowing. Very good.
Yeah, as you said, the white to white, the IOL mass is showing only 10.2 in this patient. The cornea looks like a smaller cornea than the usual cornea. The white to white measurement in this is showing only 10.2 in IOL master. So
I guess maybe tucking was not done properly. That is also an issue. Sometimes what happens if you don't tuck it properly, then the haptic slips out, and then it erodes the conjunctiva and comes out.
What is the next case?
Next case is a subluxated with the secondary glaucoma. They are done YAG PI outside, and the pressures are well under control. So this patient is having a temporal nasal subluxation.
So who's operating the case?
Prabhu, Dr. Prabhu only. Say they have done a PI. There is a PI temporally. So if it slips, he does vitreoretina also. If it does slips down, he can manage tomorrow on Monday. He can remove it.
So best is to leave, to such a person who can manage everything.
Yeah.
Iris hook ready பண்ணி வெச்சுக்கோமா. Iris hook ready பண்ணி வெச்சுக்கோ. Ready by leaving.
So there's a comment by Dr. Karan Bhatia. It says that, would you like to trim the haptic more, because trimming the haptic makes the IOL more taut and reduces the pseudophacodonosis. Rajesh, would you want to respond to that? Or I thought the trimming was adequate or optimal in the case that...
trimming, I don't know whether trimming will reduce the pseudophacodonosis, because pseudophacodonosis is basically because it is stuck at 2 points, not the segment. So when the IOL is fixed at 2 points, then the pseudophacodermosis will be there. So tucking more, trimming more will reduce pseudophacodermosis. I'm not too sure about that. I think adequate trimming, when you can see that IOL is well centered.
So when you put trypan blue, Dr. Prabhu, sometimes, especially in a subluxation, it can go at the back and can distort your, red glow. So, Dr. Reddy, would you want to comment on that?
Not much. So I missed it. I was talking some.
No, I'm saying sometimes what happens is when you put this trypan blue and your zonules are,
Yeah, it goes into the vitreous. I don't like. He's doing, as you're telling rightly true, it goes into the vitreous, then we have to use a lot of illumination. Sometimes the bulb will switch off after.
So how much subluxation is there? It looks like as though it's about 3 to 4 o'clock.
No, nothing like that. It's not clearly visible because the lens is in the place, but I feel it has to come like ICC. That's what my feeling. But he says he will try Phaco. If I plan for this surgery, I will plan for ICCE and do a iris claw, posterior iris claw, because pupil is very nice, it's small, it's reasonably good. There's a lot of movement, though the lens is not showing subluxation and there is no ephakic and pseudo lens portion. But personally, looking at slit lamp, I feel all the journals gone. It is just staying there.
In such cases, doing a capsulorhexis also becomes tricky, Rajesh, because you give a neck and then because those zonules are weak, so it doesn't quite, go from the capsulorhexis. There's no counter pressure for the rhexis to be done optimally. I think with these cases, comes the real teaching, because when you do get, these are the videos which you will not see live anywhere. And thanks Shankar Eye Hospital as well as Dr. Prabhu and Dr. Reddy for showing us this, because these would be shown edited. And when you do editing of these kind of videos, then you can really edit quite a bit. But when you see it live, then you really know what the real life problems or situations are. And I think ILM, even we use, I think we've seen here also ILM peeling forceps being used, and we use it also quite a lot. We also don't.
Actually, Dr. Prabhu is a retina surgeon also, no? So
yeah, so he has an inventory of retinal instruments as well.
Yeah, they got used to that instrument. They don't like to use
our micro forceps. Yeah, quite.
Yeah, very crude. They say very crude and.
So I think again a small rhexis is fashioned, and I think he's going to now spiral it out to make it a little bigger. Excellent control, but on the forceps and on the rhexis both. So what would be your percentage, Dr. Reddy, of glued IOL vis-a-vis, vis-a-vis posterior fixation of the iris claw lenses? And do you do both, or do you prefer one over the other?
When the iris is damaged due to in traumatic cases, or in cases where already the iris is dilated and fixed more than 5 millimeter, we go for scleral fixation or glued IOL or M&A. Otherwise, if the iris is good, generally we prefer posterior iris claw.
Any age preference in those, like?
No, nothing.
Yeah.
Because the first paper in academy, I think 10 years back when we presented pediatric age group, 3 years, 4 years, kids with subluxed lenses, congenital or Marfan's with a iris claw. We are following. We had few subluxation, few lenses where disenclavation due to trauma, but as it is, nothing as it is with the trauma. And we had at least one or two cases of detachment, which we had here. Maybe they might have seen other patients somewhere, but that's okay. That's acceptable, in case of subluxated detachments are not uncommon.
Yeah. I will not be bothered about detachment. The only thing in pediatric age group is that they have a long life to live, and iris atrophy and disenclavation in pediatric age group is something about which I may be worried. But I guess you have a large series of such cases.
I think Dr. Prabhu is meanwhile trying to put the CTR, the capsule through the rexes. And that too, I think he's showing very gently, he's putting bit by bit because the rexus is also small, but perfect movements inside the anterior chamber with the help of the Sinski and outside with the help of the forceps. I think that's a McPherson forceps if I'm not wrong.
Somehow the CTR went inside against the all laws of physics.
Yeah. I also thought as much. The CTR is, obeying Dr. Prabhu's commands. So even Dr. Reddy, myself and Rajesh, we thought, how, I'm sure they would be thinking just like I was thinking that how would the CTR go through the small rexes?
Yeah.
So would you consider putting hooks onto the capsule, Dr. Reddy, if you were to do this case, or would you?
That's what, yes, what you told is exactly correct. I think he needs hooks to hold the capsule. I kept them ready, but somehow so far he has not used it. Maybe he's going to use now after enlargement.
So we've seen wonderful demonstrations of, enlarging the capsulorhexis in two cases, first in the white cataract, and now in the subluxated cataract. And in the white cataract, maybe it is a little easier, but in a subluxated cataract, it's not that easy to, enlarge a capsulorhexis, I think, but has been done quite well.
He's planning to see how much it moves after hydro, and then he want to decide about the capsular hooks. Because he's a posterior segment surgeon, he's not worried, tomorrow he can remove it. Otherwise, if we want to do it, we have to request him. And,
to stand with you.
Then the patient also asks why you are not operated. Now it is not a problem. You will just go and tell the patient tomorrow I will do it.
So I think that way, Rajesh, posterior segment surgeons who do these kind of surgeries are bolder as compared to the anterior segment surgeons like us, who, or like me rather, you still have, you are still bolder than I am. So who are
Definitely, it does help that you are confident that you can handle it yourself. So for something about which if you can do it yourself, that gives you more confidence.
So I think we've answered that question. There was this question by Dr. Deepak Kumar Dodamani from Davangere. So you can see so many people are watching from so many places. Why not use capsular hooks? So I think that call can be later on.
Yeah.
And what are your parameters, Dr. Reddy, at this point in time while...
The Phaco, he uses standard 400 vacuum, 36 flow rate and 60 power with white star, I think around 40% is the 35 to 40% is the and is 36. I use different parameters and he likes that. Something. There was some small problem with the student somewhere.
Okay, now I think we can see the console very well. Earlier it was not visible about the various parameters, and I think we have to parameters should be lower for subluxated cataract. So, Rajesh, what do you think? I mean, we should do a slow motion kind of a phacoemulsification with a flow rate that is not very high, aspiration again not very high.
Yeah, I agree with you. I agree with you. In such a case, slow motion phacoemulsification will be preferred.
The side Suchir Kumar. இது டர்ன் பண்ணிருக்கும்.
So for all these cases like posterior polar cataract, for subluxated cataract, for cases which are post where surgery has been done, I think one should consciously lower the parameter with a less vacuum, less flow rate, etc.
What you are planning? Now, what is the planning as he is going to my, I think,
okay.
There is some temporal. So,
So I think at this point in time, if you are really not this thing that you can continue with phaco, you can actually do a little bit of vitrectomy there and then extend your rexes and then maybe just deliver the lens.
Or the other option is that we can do a little bit of vitrectomy and maybe hold the capsule by capsule hooks on all sides. So that will stretch and bring the capsule to the periphery and then go ahead and complete the phaco, and after that see what is the capsular status. Depending upon that, we can fix the bag.
Question, Rajesh, and the question is by Dr. PVL Narasimha Rao, and he's asking that should you hydrodissection should be done before introducing the CTR or after introducing the CTR, and what do you want to say for that?
See, I mean, it all depends on how comfortable you are. Yes, before putting the CTR, hydro procedure will be easier because then your movement of the whole chunk will be definitely easier. So that is something one can prefer. The other thing is that in such a case, there can be people like, one may not use CTR at that stage and maybe just use a capsule hook, support the lens and go ahead and complete the phaco. And then after that, depending upon the amount of subluxation, either you put an endocapsular ring or you do a single point fixation, put a segment or whatever. So that gives you a little bit of flexibility if you support the capsule with the capsule hooks. And there
In this case, he is planning not for capsular support. He is thinking that the lens is too weak, the journules. So he needs some type of fixation for the capsular bag to be stable. Something like a Sian ring or something like that to make it more stable. So now he's planning for a lens removal with the posterior iris claw in this case.
Okay.
And so he shifted to temporal section.
Yeah, so I think
so superior, from temporal to superior. Yeah.
So I think, Dr. Reddy, you would have done so many retrofixation of iris claw lenses, and we've not seen any. I haven't seen anterior iris claw lenses, which we used to do, the phakic lenses. There we've seen disinclination, which happens, you know, because of trivial trauma, etc. But have you seen these posterior fixated lenses?
Yes, we have.
How is the disinclination here?
We had disinclination of posterior after trauma, but mostly it is, you know, one get inserted, not both, and with dislocated iris claw into the vitreous full lens, not seen. Most of the time, it is only the one enclavation, one claw will get disinclaved. But that one refixing is a little tricky. What happens is when the patient lies down, the lens goes vertically down. You can't see the lens. For posterior segment surgeons, it's easy. They go through pars plana and lift it. For anterior segment, when we don't go through pars plana, lifting the lens is a bit tricky, but we learned the trick now. After doing few cases, we just go blindly with a Sinskey hook and lift it. We are able to bring them back and re-enclavate.
Actually, in some of these, a few of such cases, pediatric cases, I had seen disinclination and the lens hanging in the vitreous cavity. So that was, in those cases, I've removed and I've done the intrascleral haptic fixation in those eyes. So from then onwards, after that series, I felt that probably maybe in children, the risk of disinclination is higher for two reasons. One is they are prone to trauma. Number two, they have a long life to live. So the risk of atrophy of iris and disinclination may be higher in those.
Yeah, especially children, as you are telling, you know, we cannot warn them saying that you will get a disinclination. They can't understand. Once they see the vision well and they go and play outside, you cannot receive. Whereas adults, it's okay, we can tell them. So definitely children, the trauma is a big problem. Trivial trauma will
I also wanted to ask your opinion on one thing, Dr. Reddy. I'm sure, I mean, in your hospital, people would have moved from monofocal to Eye-Hans kind of a lens. So what percentage of monofocals have you converted into, in your practice, to Eye-Hans IOL? And in government institution like ours, there's not saying there is not too much of a difference, but there's not a difference as much as you have in the pricing of multifocal vis-a-vis monofocal. So what percentage would you have converted your monofocals to Eye-Hans kind of a IOL?
Now it's more than 50%. When the patient pays for it and get the surgery done, it's not a question of insurance reimbursement, cashless. Almost 100% of 90%, more than 90%, unless we need a toric for the patient for cylindrical because they are not having Eye-Hans toric. Only the cashless portion, the Eye-Hans still is not covered by cashless insurance in Coimbatore. I don't know about the other places. Those patients, they are going for that monofocal, regular monofocal. So
and some people, you know, when they're using Eye-Hans, they are doing a little bit of kind of a micro monovision kind of a thing, maybe slightly overcorrecting in one eye and leaving the other eye metrope, so that, you know, they can get a more range. Maybe for near also the patient can manage. For people who are not too demanding for near, like for housewives, etc., it can work for both. I mean, that's what some people do. What is your take on that?
Yeah, that's a very good point. What we observed, especially for the phone, cell phone, all they can manage very well.
Yeah.
But only trick there is a lot of when we discussing with my colleagues, they say is when they do mono vision, the second patient always compares with the first eye and says, my first eye vision distance is better than my second eye.
Yeah.
Whatever you explain, they say that. So what I am doing is right now, when I am doing planning for a micro mono vision, first eye I put slightly myopic.
Okay.
First eye I put 0.5 or more than 0.5 diopters, more myopic. And anyway, we will be operating more cataract eye, dense cataract eye first eye. When you put the second eye, when they compare, they don't find any problem to complain, so they are more comfortable. Instead of doing second eye myopic, I do the first eye more myopic.
And if this thing can be explained to them that you may not require glasses for your day-to-day activities, we are doing this, then maybe people who don't have too much of precision work, they may agree for it as well.
I think coming back to the case, Dr. Prabhu has made an incision which is
some vitreous is there, he is cutting, I think.
Yeah. So some vitreous is there which he's cutting, which is aptly so, because when the lens is going to be delivered, then obviously it should not disturb too much of vitreous, although it would still. And this is what is the size of the incision that he would have made, which is almost like a straight incision?
It's around 6.5 millimeters he made, but I like more. I like around 7.5. Maybe he will enlarge. I'm just watching.
I think he did enlarge also while we were talking. He did enlarge it and
nicely.
Yeah. And this is the lens with which is
with the endocapsular ring as well, which is shining,
Yeah.
at the edge of the capsular in the back.
And then this is with the vectors that it is coming out. The nucleus is large, I think, in this case, not so small a nucleus. But delivered and then so I think those are great tips, that once you're doing a procedure from the temporal incision and you actually have to do enlarge the incision, then it is always best to change the site of the incision rather than enlarge that temporal incision, because the nucleus was so large that even if we would have enlarged it to about half, it would not have come out from the temporal side, especially because the corneal diameters, if you see, they are much bigger horizontally than vertically.
This is another.
So I think he intends to do vitrectomy, and that is why that incision is being closed using a suture. Rajesh, what do you think?
I guess, vitrectomy can be done with the side ports. Maybe he has some other plans.
I didn't ask him why he is putting suture.
Yeah.
Yeah, he want, because they got used to posterior segment vitrectomy in a tight eye. He want to create a tight eye.
Okay.
So these are great tips. I mean, it doesn't take too much time to put that suture, and then
Yeah.
vitrectomy can be more controlled rather than, with the open incision.
So, will he go through the pars plana or what?
I think not.
Anterior only.
Can
Anterior
do
only.
anterior only.
Okay.
Pars plana, I think making ports pars plana at this point in time is also going to be tricky because of the
Soft time, yeah.
yeah.
Now, this particular microscope, we are not having biome. That is in another theater.
Okay.
Not having biome.
So the vitrectomy that he's using is attached to the same machine.
Yeah. It's for Signature Pro. The cutting rate is little better than the old models. This is around 2,500 and the maximum. And it's a pneumatic cutter, not like the usually J&J, the older machines, they are having the electrical cutters, whereas this one is a pneumatic cutter.
So what was the cause of the subluxation? Was it a trauma?
Trauma, yeah.
And how old is the patient? Sorry, I missed that. How old is this patient?
He had a trauma sometime back, and he landed with a glaucoma. So they did a YAG PI and controlled the pressure, and he left it like that for some time, for a few months. Now, once the vision drops down, and he came for cataract surgery. He's an anti-glaucoma with a PI.
What's the age of the patient? Age
of 65 years.
65. So I think in this case we'll do posterior iris fixation after.
That's what. Yeah, this once we have to put pilocar, and if the pupil constricts, I didn't see this patient pre-operatively. This is he saw this patient. He's saying pupil is quite okay. If it doesn't constrict, then we have to plan for a scleral fixated lens. If it constricts, then it's okay. He's lucky. He can finish.
So we do know that there is a eyelet which is there in the Sionis ring. There is a question: is there any CTR sort of a ring in which there are multiple eyelets? I don't think to not.
Yes, Sioni. No. Sioni ring has one is single eyelet one is double eyelet one. So in that you can fix it on both sides with a double eyelet Sioni ring.
So even Dr. Devdutt Thomas, I think he's from Coimbatore only and a good friend of ours also.
Yeah.
He says posterior iris claw is the best option for subluxated lens rather than the long-term risk of IOL drop with the in-the-bag IOL. So I think he's also a retina glaucoma.
He usually looks after glaucoma. They have more pseudo exfoliations and sort of things, small pupil pseudo exfoliation cases. So the surprises are quite common for glaucoma people. But nowadays, most of the glaucoma surgeons in Coimbatore, initially they used to do scleral fixation, refer to retina surgeons, but most of them now they turn to posterior iris claw for their glaucoma, either due to spirophakia or due to traumatic subluxated cataracts. Most of them are doing now iris claw.
Okay. After putting pilo, do you prefer putting these triamcinolone, etc., to see, to ensure complete removal of vitreous?
Also, Dr. Meena Lakshmipati wants to know, Rajesh, I think you can answer this question. Why not? I mean, why not make that corneal incision only bigger? I mean, corneal section only bigger and then deliver the lens. I think that is an option. The only thing is your whole section is going to be then corneal.
Yeah. See, that is definitely an option. The only thing is that when you are creating a kind of a small incision, SICS kind of a wound, then you may not require too many sutures, and this will be, on the superior side. Otherwise, temporarily there will be a large incision, and that will be exposed. Although, I mean, that is an option and that can be done. Yes.
So the pupil is being constricted, and it has constricted quite a bit. Would you consider this much amount of constriction okay for a posterior fixation of iris claw lens, Dr. Reddy, or would you want it to constrict a little more?
This is okay for doing enclavation, but post-operatively, this big size may produce some visual symptoms, because the optic is usually 5.5 mm in iris claw. It's not 6 millimeter. The optic size is smaller. In India, we are having only 5.5.
Yeah, true.
But he is telling that he saw the patient preoperatively, pupil is less than 4 millimeter. So even if it doesn't constrict now, it may constrict because it dilated for surgery. It is refusing to constrict. But as it is, there is no transplant staining of much. Vitreous. It is only maybe there a little bit stands, but we are not seeing it.
So I think triamcinolone has been put. There were people who were suggesting it, and there doesn't seem to be any vitreous in the. I think Dr. Prabhu is doing a little bit of vitrectomy for those small strands which are present in the anterior, just in the center of the pupil.
I will also completely agree with what Dr. Prabhu did. Like, you should try to make the pupil a little smaller so that the triamcinolone doesn't go posteriorly, and then put triamcinolone so that that will stain the vitreous that is there in the anterior chamber.
I think again that's a great tip, Rajesh. Both you and Dr. Prabhu has demonstrated, and you've spoken, because sometimes what happens, the pupil is very big and you put triamcinolone, then again the glow goes for a 6. And you can't see anything, it's totally white.
And plus it goes posteriorly, it will remain like that as a depot.
Yeah, I think
long and
it will be really nice to see how the posterior fixation of the iris claw lens is done in this case. So Rajesh, if you were to do this, would you also do a posterior fixation, or would you leave the case and then do a glue dowel at a later date? Because I know for people who are not doing posterior fixation of the lenses, there are two options. One is that you put a AC IOL here, or two is that you put a glued IOL you do at a later date. So what would be your option for a case like this?
For a case like this, my personal option, you also know that I have a little.
You are a glued IOL man.
Towards glued IOL. So I'll put a couple of sutures, make the chamber tight, put an AC maintainer, do a vitrectomy, and then once the globe is a little tight, I will create flaps and then do an intrascleral haptic fixation of glued IOL.
In the same sitting or at a later date? Because
I would see if the patient is cooperative and if the patient is under block, or if I have managed to do a subtenon, I would do it in the same sitting.
So I think these cases, they always should be tackled in block only, because you don't know.
If you have not done the block and you are doing it under topical, then a very easy technique is to give a subtenon block, and that does not even raise the IOP much. And with the 2 to 3 ml of subtenon block, you can have the eye still, and you can go ahead, put a suture, do vitrectomy, then create flaps and fix the IOL. So that is something that can be done. But sometimes what happens that while you're doing it and the patient has become a bit uncooperative, and you feel that, patient may not you are finding it difficult, then there's no harm in explaining to the patient what sutures, leave the patient efficacy, and you can fix the IOL at a second sitting. But in the same sitting also, it is very much possible. But what is most important is put the suture first, do a vitrectomy, make the globe a bit, tense so that you can create a flap.
So I think suture has been removed, and Dr. Prabhu is going to put iris claw lens.
Yeah.
He showed that lens, and he's going to do a retro fixation of the iris claw lens. Again, I think this is the first ever retro fixation of the iris claw lens that we would be showing in the AIOS Surginar. We've never had a demonstration of this, and thank you for doing this, Dr. Prabhu and Shankara Eye Hospital, for demonstrating this live. That too, it's not easy to do these things live.
And that too unplanned, not unplanned, I would say, but not previously planned that you have to go for iris claw lens only. And in the middle of the surgery, when you felt that the need for doing it and you are managing it so well, that is something which, I would really like to congratulate Dr. Prabhu for handling the case very well.
So Dr. Reddy, now over to you for the steps of iris claw.
Yeah, this is basically we developed in-house with a company called Chennai-based company, Excel Optics. This is the design is specifically made planar design. This is the only lens available in the world for aphakia with a planar optics. There is no angulation. It is either you can put either way the lens, and the size is 5.5. And we made two types at the time. One is 9 millimeter, one is 8.8 millimeter. But somehow nobody liked 9 millimeters. Everybody started using 8 millimeter. So we discontinued 9 millimeter model. And this one is continuing. It's almost more than 10 years now. Initially, to know the popularity of the lens, I asked the company people, what is your sales or something like that. The initial sales are around, they were selling 50 to 100 lenses per month. Now they are reaching almost 400 to 600 lenses, depending upon the fluctuating almost per month. So that says its popularity is slowly increasing and people are accepting it.
So it was a beautiful tuck that Dr. Prabhu did on one side.
Yeah, yes, we missed it. We
we just blinked our eyes and it was done, with just a blink, it was over. So I think we have to be very carefully watch the next tuck which is going to be done. He's just
generally we do a PI, but we don't do in this case because we got already two YAG PIs, one at say 5 o'clock and one at temporal. The surgery is over. Whether he will put a sutures or not, I don't know. I have to wait and see whether he likes to. Probably you put a suture. Two sutures he is planning for the scleral section. Generally, sometimes even the section is very good. You don't need sutures also. This type of complicated cases, we don't want to take a chance.
Actually, a vitrectomized eye may not be that tight, so that's why maybe putting a suture is a very good idea.
Yeah, so we like to put two sutures, and the conjunctiva generally we close that with a glue also because the patients are already having inflamed eye. We want to give as comfortable eye as possible for the patient. So the conjunctiva we close with the glue, tissel glue. It's a very comfortable.
But what a fantastic case, and I would like to inform everybody that it is such a glued audience in the sense that whosoever was there with us, and it's a huge number of audience at Facebook, at YouTube, and at our platform, has stayed till the very end because of the absolutely fantastic performance of the surgeons and the wonderful surgeries and a variety of surgeries, and they were managed so well in a real time situation. Plan A was changed to plan B, and yet the results are so good.
Yeah, actually, to tell you honestly, I was also completely focused at what moves he is making. because this was a great learning experience. I really, love to handle such cases. We all love to handle such cases. The way Dr. Prabhu has done it, it is really
fantastic.
Fantastic. There's no doubt about it.
So there are so many congratulatory messages. Dr. Satalkar, wonderful surgery. Congratulations, Dr. Sarvana Bhava. Excellent. Excel IOL is very good. Excel IOL are quite good. I think he would have also done himself, and he wants to complement these intraocular lenses. Dr. Reddy, you should tell us more about these lenses, because I thought the size, the optic size was larger in these lenses.
Yeah, that's what I also felt, that I have seen a couple of, not a couple, I mean, by a number of, these retrofixated lenses. The optic size in those lenses appears to be slightly smaller than what I could see in this.
Professor Daljit Singh, he prefers 5 or 4.75 optic. So everybody used to make the same size. And so, but we thought that is too small. So we designed it 5.5. 6 millimeters also good, but 6 millimeters again, when something happens during phaco and you are doing, you don't make a 6 millimeter section, it becomes too big. So we settled with 5.5.
So I don't know how many compliments are there. Dr. Arun Sethi, interesting cases and neat surgeries. Sachin Agarwal, fantastic surgery. Dr. Jogender Chog, fantastic indeed. Dr. Raju Manthalkar, wonderfully done. Congrats, Dr. Prabhu. Dr. Venkat Raman, Vital Devani, again, congrats, Dr. Prabhu. I mean, it was just mind-blowing. We've had one of the best sessions, I think, as far as the Surginars go.
True.
So he's planning to suture even temporal. He doesn't want to take a chance,
Yeah.
Little complicated case. We want to give as maximum protection as possible, not to bring the patient back to the OR room. We don't want to bring him back for any minor things. So the temporal.
So just fantastic. I mean, we had a wonderful set of surgeries. Rajesh, would you want to say something?
Yeah, I'm just watching. It's the hands, the steady hands of Dr. Prabhu is really, has shown how good he is in these surgeries. And in such scenarios only, we, really get to know, we learn so many things. And the surgery was absolutely mind-blowing, There's no doubt about it. So, and the way he handled it, the way he, planned in the middle of the procedure. I mean, planning before the procedure is much easier, but when you are stuck up and when you get such scenarios and then you plan again, I mean, that is something which is really commendable, and he did it very well.
And these cases, like a case like this, if you edit and you show, you would never know, what went behind.
True.
How this case was really managed. You can make a beautiful edited video, but management in a real-time scenario is something which we all need to know, because that is something one is actually faced with.
This conjunctiva, once we leave it, it's okay, it covers. But
I was just wondering what he's doing, because there was a little bit of.
We all were wondering what he would do with the peak pupil.
Once the tag has come somewhere. During hydration, I think it has come. Once we cut with. Stags, they whatever vitrectomy they told, because I don't know much about vitrectomy, we do rarely. But for anti-segment surgeons, cutting with a vitreous cutter, the tags is terrible. You cut them, they don't come. They're so thin, it won't get sucked into the vitrectomy probe. Though this is better cut with scissors, I found. I don't know how do you manage, Rajesh, when there is small, thin lines, hanging to the incision, to the pupil.
You can just maybe, I use cutter only for that. and just do a swiping movement without, putting the cutter on, see if there is any strand. And if I can see the strand, I just pull it, bring it in the center, and then with the cutter, I cut it. But sometimes, yes, sometimes these micro scissors can be very useful. You just cut it flush at the edge, and the taut strand, it goes behind. So that works.
We have audience from Hong Kong and from China as well. And again, this thing is fantastic.
So your lens is going to go to China.
Fantastic, wonderful, great. So all these comments, like I said, we've never had so much of people watching. Dr.
Prabhu,
many
congratulations. Great surgeries.
It's thumbs
Wonderful
up.
Surgeries.
Now will Dr. Prabhu speak?
Dr. Siddharth is here.
Yeah, you can see the two heroes.
The three heroes. The most important hero is Dr. Jagdish Reddy.
Yeah. That is true. That is true.
Yeah. So excellent, I think. I mean, what a fantastic demonstration of surgeries, and thanks to your entire team of the nursing staff and people who are there in the OR as well as the patients. Surgery.
I guess the quality of a great surgeon is that he maintains his cool. And I've seen Dr. Reddy maintaining his cool every time. I guess, and Dr. Siddharth and Dr. Prabhu also maintained their cool very well. I mean, Dr. Siddharth didn't have to maintain his cool. He finished before we actually thought that it's going to finish. Dr. Prabhu in the last case had in between had some issues to think about, and the way he managed it was superb. So these are the surgeries which really teach you how to do things, and the finer nuances of all these. And Dr. Reddy, I would like to congratulate you a lot, because you have been doing a lot of innovations. I mean, so many things you have done. You have worked with the Indian companies and innovated quite a lot. So many congratulations to the whole team.
So Dr. Prabhu, any last word?
Yeah, this is,
Ma'am, thanks a lot.
Thank you for showing us such.
Thanks, Dr. Rajesh.
Thanks to you to show us such a fantastic surgery.
No, for all the comments.
And Siddharthan, I told you, the whole India is going to send you only now.
Yeah. What a beautiful DMEK you have done. Wonderful. Mind-blowing.
Thank you, Rajesh.
Yeah.
So, Dr. Reddy, would you want to say something, or we can continue?
Nothing for, thank you again for giving us the chance for allowing us to be seen by other people in the other part of the countries and different countries. Thank you very much. So you may be wondering why this guy has not operated.
Yes.
So
that's $1 million question, but
yeah.
We would
when I was young, I have a lot of desire to do live surgery. I never get an opportunity. I rarely used to get a small chances operate before 30, 40 surgeons. So these are like my kids. I am godfather for them. They have no father-in-law to push them up. So I have to take care of them.
Fantastic.
That's big salute to you. We salute you, Dr. Reddy. We salute you
for that, and fantastic sentiment, which I think all teachers should have. And you have your students are carrying forward your legacy. So I know you are a great surgeon yourself, and you didn't operate today, but fantastic.
That's really true, Namrata, because I owe a lot of surgeries, my skills. First, when I was in Aravind, to Dr. Reddy, she was a different cadre of surgeon, like very conservative, and I learned a lot from her. But after coming here, Dr. Reddy was entirely opposite, like very daring. So I used to see both of them. So I have a balance. So I really owe both of them And this platform, I want to thank both of them and JK sir for giving this opportunity, and thank you.
Thank you, Dr. Siddharthan. Keep doing the good work. You are too good.
So we pulled few more cases because we cannot be so no. So I told him to finish that cases. Okay, we can with this we can.
Thank you so much. Thank you, Dr. Reddy, to allow us to see your OT and your great surgeons and great surgery. I know a lot goes into organization of live surgery shows, but this is one for the archives. We are going to showcase it because it was really, if I may say, the best Surginar we've had till today. And
definitely, I completely agree with you. Completely agree with you.
Yeah,
all the surgeries were mind blowing.
I would like to thank J&J for supporting this cause. At this point in time, I would like to remember Mr. Jaswinder Ji from J&J. You see the background which is behind me was designed by him when we did the webinars. And the concept of Surginar and the title that is there, it is all in your hands, was again something which, was thought by him. So he's no more with us because of COVID, but yes, we would like to remember him. And thank you very much, everybody. Thank you, Mr. Himanshu, Mr. Ashutosh, Mr. Gaurav Agarwal, our AV team, Himanshu from J&J, Ashutosh from J&J, who's been coordinating. And thank you, Kripal Rana, for the mailing, as well as for the support from the back end. And of course, the heroes of today, Dr. Reddy, Dr. Siddharthan, and Dr. Prabhu.